We'll move on to our next speaker, Dr. David MACKEY, who's done a lot of work on lifestyle measures, and he'll be speaking on low concentration atropine in myopia. He works at the University of Western Australia and is an avid researcher as well. Dr. David.
Thank you very much, and an honour to be able to speak at the session. How do I advance? Right. I have no disclosures, and I love Jonas Salk's quote when he was asked why he hadn't patented the vaccine. This is a summary sheet of what we're developing for giving to parents. In Australia, we don't have high rates of myopia. We have high rates of skin cancer, as you saw from our lovely blue skies, particularly in Western Australia, with the prediction that we could be doubling in the next 50 years, though in Western Australia, adults who had had skin cancer have half the rate of myopia of the general population, showing that if you have enough sun to get skin cancer, you're going to have less myopia. And then when we look at the risk of if your parents have myopia, with no parents it's 20%, one parent 33%, and two parents 44%. And as we know, the time outdoors, near work and education are important factors with that. So the things for slowing myopia, we have, of course, Atropine and the other treatments, but we in Australia have to balance this challenge of what's been over 25 years of sun protection in children to accommodate those recommendations that the parents are well aware of with the increased time outdoors. So one of the approaches we're looking at is promoting outdoor time early in the day and late in the day when the UV index is below 3, and therefore we shouldn't be causing adverse problems. Now, looking at the Atropine studies, I feel a bit embarrassed standing up here with Jason Lan behind me, and that he has, this incredible, number of papers that really are the, gold standard of this. We were looking at the Atropine studies as they're coming out. I've known Audrey Cheer since she was a trainee in Australia. And this phenomenon of the rebound effect with the higher dose atropines was of concern, but it wasn't thought to be present with the low concentration, 0.01, but it had never been done as a head-to-head placebo low concentration, and that was one of the things we wanted to look at in Australia. We'd presumed that with more blue-eyed people, the lower concentration might work better in Australia. And we worked in harmony with the UK group and the Irish group, who were doing similar studies, so that we were able to meta-analyse our studies together, and we have also been working with the other previous studies. Now, this was the original publication. Now, you can see there is a clear difference at the 6 months, 12 months and 18-month period. And then we had this very bizarre phenomenon of we didn't meet our primary endpoint of a 2-year significant difference. But you can see this hockey stick shape to the red line, which are the placebo group. And what was happening there is that the parents knew their child was progressing, and they were concerned they might be in the placebo arm, and we in fact lost more of the placebo arm children than we did of the treatment arm children, and this altered our statistical outcome. Now, I'm pointing this out because it's going to be a problem with any of our trials that parents, particularly the tiger mum who says, I want my child getting all of the best things, and even though we're in this trial where we're meant to follow this protocol, they may not. When we looked at the difference in ethnicity, we had about a quarter East Asian and South Asian. We didn't see as much benefit in that group, although we are now meta-analysing this with the studies from Asia and show that there is actually some effect with the lowest concentration, though generally in Australia people are starting with a slightly higher concentration in darker-eyed children. Now, this was the incredibly disappointing thing. Going back to the original Singapore study, is there actually a rebound? Well, in fact, with the low concentration, 0.01%, at the end of the 1-year washout, we literally were back at the beginning again. All the benefit from the 2 years had disappeared. So Atropine is not a 2-year commitment, it's a much longer commitment if we're putting children on this treatment. When do we stop? I don't know, but I think I would keep going. We were worried, particularly with the bluer-eyed individuals, that the slight pupil dilation and accommodative blur might be greater, and definitely in the bright sunshine of Western Australia, whether this might stop the children going outside and in fact get a contra effect from the treatments. But we didn't notice any difference in the symptoms when we were masked and compared the treatment and control. However, the actual pupillometry and accommodative measurement did show a difference between the children on the treatment. Another interesting thing was looking at the choroidal thickness change. This is a really clever piece of work that Sam Lee had done. And we showed here a dramatic rebound with the choroidal thickening. You can see here. And I think this is an area that we need to be looking into more, because choroidal thickness increases normally and the treatments boost that up against the lack of choroidal thickening that we see with myopia. So an area of research, anyone looking into this, please get choroidal thickness measurements. Now in the United States, they ran 2 really big studies. One said it works and the other one said it didn't. And that's really thrown a lot of confusion into the area whether we're treating children or not treating children. Now, of note was the impact of COVID-19. You've already heard of that in the previous study, where that halted the progression of improvement in rates of myopia. And the age group that the studies in China and Hong Kong showed that were most impacted were the younger primary school age children, as in the younger children that we would get in the studies. Now, when we looked at the Western Australian Atropine for Myopia study, effectively there was a lockdown and effect, but we had a very short lockdown, similar to China's lockdown, in that we then had abolished COVID in Western Australia. We couldn't leave the state, but we could go outside and do everything as usual. And the rate of elongation in those in the placebo arm was similar during lockdown and not lockdown. So it looks like the lockdown and the atropine interact. And again, with the Mosaic study from Ireland, they compared the children who had a low COVID impact, where you see a difference between the treatment and controls, and those children who had a high COVID impact, the benefit disappeared. So I think outdoors and atropine need to be considered as a combination treatment to get the maximum benefit. Now, looking at this issue of summer and winter, I was surprised that we would see any effect. I know in places like Northern Europe, in winter, children are inside, it's hard to go outside, and there isn't many hours of sunlight. Western Australia's bright and sunny, and I thought that we wouldn't see much difference. But in fact, the axial elongation in the winter months is double that in the summer months. So we're getting an effect there, and it may be that's when we need to really concentrate on all our treatments for these children. So in conclusion, our low concentration atropine shows a rapid effect in children of European ancestry, less so in Asian ancestry, but probably needing a higher concentration. We showed a significant rebound after cessation, all the benefit lost in a year, and increased choroidal thickness, but a major rebound on cessation. So the interact of the COVID restrictions were reduced outdoor time and increased screen time are interacting with atropine, and therefore I think we need to be looking at combination treatments. Most health systems aren't readily funding low concentration atropine treatment, and this is a challenge in Australia, where the wealthier children are going to be able to get all the treatments, but the poorer children are just going to be in schools and eventually given glasses. We also think that the axial length's probably the easiest thing to test in children in population-based screening and studies, as the children don't have the problem of objecting to the drops. And if you can do OCTs to get choroidal thickness, that would be of great interest. And masked clinical trials, although I've said they'll be difficult for children who are myopic, I think we will be able to do this on pre-myopic interventions because the parents don't know if their child's very pre-myopic or slightly pre-myopic, and I think this is something we should be looking into more. I'd like to acknowledge Sam Lee, Gareth Lingham and Anthony Clark and the main clinicians involved in this, and our funding and collaboration with the Mosaic and CHAMP studies, and Audrey Chia, who's on our Scientific Safety Committee from the ATOM study.